Tracheostomy after 7 days on the ventilator in ICU. Right timing or too early? My name is Patrik Hutzel from intensivcareoutline.com with another quick tip for families of critically ill patients in intensive care, where we help you to make informed decisions, have peace of mind, control, power, and influence, making sure your loved one always gets best care and treatment, even if you're not a doctor or a nurse in intensive care. Today, I want to answer a question from one of our members who says, today I happened to discuss with one of the intensivist doctors by the name of Raza at the hospital. He was saying like weaning off a ventilator is going to be difficult as my mom is in a limited consciousness state. She cannot handle her secretions. He was giving me the option whether my mother would like to have a tracheostomy and then weaning and then moving to a long-term acute care nursing facility. I said yes to it. I'm a bit frightened and concerned that medical professionals are rushing to move her out of ICU. They're not trying to just wean off the ventilator without the tracheostomy. Today is the 7th day of ventilator support. She seems to have done spontaneous breathing trials for about a couple of hours for the past 3 to 4 days. Do you think they have to delay the tracheostomy? They are making plans to do a tracheostomy tomorrow and the feeding tube the following day. Is this a good approach for her going forward, as she is minimally responsive and not having much success with straight weaning off process? Now, here's my take on this. A tracheostomy after 7 to 10 days of ventilation in ICU is usually standard practice if a patient can't be weaned off the ventilator and the breathing tube. Why? Because a tracheostomy is much more comfortable than having a breathing tube in the mouth. It reduces the need for sedation, which is critical for recovery and assessing brain function. It also reduces the need for opiates, which is also critical for recovery and assessing brain function. Opiates are medications such as morphine, fentanyl, oxycodone, oxycontin, and sedation is usually propofol, midazolam/Versed, or Precedex. A tracheostomy also helps with secretion management, especially if your loved one is minimally responsive and can't cough effectively. Now, your concern about ICU rushing to transfer your mother out to an LTAC is valid. ICUs often want to free up beds quickly, but you and your family are in control here, not the ICU. And obviously, this is from one of our members in the US, because if an ICU wants to transfer a patient to an LTAC, that is unique to the United States. LTAC stands for long-term acute care facility or long-term acute care hospital. And often when patients or when ICUs are trying to send patients to an LTAC, it means they end up with a tracheostomy and the PEG tube, and then they want to send them out. But we strictly advise against that. So your mom has tolerated spontaneous breathing trials for a few hours, which shows some potential, but not enough yet. In such cases, a tracheostomy is often the right step because it avoids repeated reintubations, which are dangerous and traumatic. So is this the right approach? Based on what you've shared, yes, a tracheostomy is a reasonable step forward if extubation attempts are failing. But you also need to clarify, will she stay in ICU for weaning, or are they planning to ship her off to a long-term care facility too quickly? A feeding tube, a PEG tube, is not a reasonable step because, number one, it's another unnecessary surgery. Number two, the perception in hospitals about PEG tubes is simply that a patient will never eat and drink again. Now think about it, is that the perception you want for your loved one? Whereas if they stay with the nasogastric tube, the perception is that it's temporary and that your loved one will need to start eating and drink again, which means the efforts the ICU team will be making towards weaning and towards, removing the tracheostomy are much bigger, and there's a higher chance for success. You don't want to put your loved one in a compromising situation where all of a sudden your loved one gives the perception to the ICU team that they will never eat and drink again. Not a good place to start off with. The bottom line, a tracheostomy is often the safer option after 7 days of ventilation when weaning hasn't worked, especially in someone who is minimally responsive. But don't let them rush into a transfer to an LTAC ever, right? Because an LTAC is simply a disaster area. I've made a video about 10 reasons why LTACs are a scam. and I will link towards that video. Also, go and check out another video that I've made, how to wean a critically ill patient off the ventilator and the breathing tube, because the goal always needs to be to try and avoid the tracheostomy, right, within the 7 to 10 day window. Now, don't get me wrong, the tracheostomy has its time and its place, but you need to be absolutely sure that, number one, the ICU has done everything beyond the shadow of a doubt to get your loved one off the breathing tube and the ventilator and avoid the tracheostomy. How can you find out if they are doing everything beyond the shadow of a doubt? Well, I'm glad you've asked, because that's how we help you. Because if you go to intensivcarehotline.com, go and book a call with me. You know, if the free tips here are already helping you, imagine how much quicker you can get results if I work with you one-on-one. It can literally cut the time to life-saving outcomes down from weeks to hours.